Hi everyone, we are very excited to present to you a symposium on chronic hand eczema. This program is supported in part by an educational grant from Leo Pharma, for which we are very grateful. So just few words about the International Eczema Council. It was founded in late 2014 and it's a global non-for-profit organization that is led by dermatology experts on atopic dermatitis. It's governed by a 13-person board of directors, and currently we have 107 counselors and associates from 24 countries that serve as expert advisors to the IEC, and we are still growing. We had many successful symposia and virtual educational programs, including in the last year in the 2020 EADV on novel systemic treatments for atopic dermatitis and clinical trial design, new treatments for atopic dermatitis in infants and children, management of atopic dermatitis patients on systemic treatments during COVID. In 2019, World Congress of Dermatology with new topical treatments and preventing mechanisms. At the SID in 2019, a symposium on barrier. At the 2019 American Academy of Dermatology, we had a very successful meeting on atopic dermatitis and alopecia areata, contrast and compare, a microbiome, and the 2018 AAD. At the ISDS, we had atopic dermatitis phenotypes and biomarkers, and many other very successful symposia. We have some future educational programs at the SID. We will have a symposium on biomarkers, and we recently had a very interesting a paper on biomarkers, a review paper published in Journal of Allergy and Clinical Immunology. We are going to have a program at the ESDR on human models of atopic dermatitis. And we are going to have a program at the World Congress for Pediatric Dermatology, as well as one at the ADV on face and sensitive areas, and at the Inflammatory Skin Disease Summit in 2021 in New York City. Again, we are coming back to alopecia areata and atopic dermatitis. So very exciting time for us. As I alluded to, we published several papers, including the recent review on biomarkers and also the recent paper on chronic hand eczema that is the topic today, but also several other papers on conjunctivitis with and without dupilumab, and also the role of bacterial skin infections in atopic dermatitis. And we have several others that are in progress now. Some of them actually accepted already or published, such as the atopic dermatitis biomarkers and several others. So very exciting time and busy time for us. You can look at the top 10 publications that we are posting every year on the IEC website, both for 2019 and for 2020 that is coming up. In terms of our disclosures, we are really grateful to the partnership with multiple pharma companies that without them, all the advances that are happening now would not have happened. We view this collaboration as really essential to bring new drugs for our patients with atopic dermatitis. And we want to thank the companies that are listed here for their partnership with the International Eczema Council. We could not have done what we are doing without you. So thank you so much. So with that, I want to present this virtual symposium on chronic hand eczema. The program chairs are Robert Bissonnette, that is actually the president-elect of the International Eczema Council, Tove Agner, that is a counselor from Denmark, and David Cohen, that is also an IEC counselor from the US. In fact, he's my colleague in New York City. And additional speakers are myself, April Armstrong, also from the United States, from California, and Jonathan Silverberg, also an IEC counselor from the United States, from Washington. And the agenda, the introduction, and we are moving on with a talk on epidemiology, hand eczema and etiology and classification by Dr. Armstrong. After that, how to run a hand eczema clinic, a very practical consideration by Tove Agner from Denmark. After that will be a talk on allergic contact hand dermatitis, David Cohen. Tools to measure severity of chronic hand eczema, Robert Bissonnet. Current therapeutic strategies, phototherapy and systemic therapy, Jonathan Silverberg, followed by a panel discussion. Thank you so much for your attention.
Hello, everyone. My name is Dr. April Armstrong. I'm Associate Dean of Clinical Research and Professor of Dermatology at the University of Southern California. I'm very excited to talk to you today about epidemiology, etiology, and classification of chronic hand eczema. Here are my disclosures. First, let's talk about definitions. In this talk, we're going to use the term eczema and dermatitis synonymously. So when we think about hand eczema, also known as hand dermatitis, it's typically defined as an inflammatory skin disease of the hands and wrists. When we think about acute hand eczema, that's typically defined as eczema localized to the hands that lasts for less than 3 months and does not occur more than once per year. And then how do we think about chronic eczema? When we look at definitions for chronic eczema, what we see is that chronic eczema is typically defined as persistence of hand eczema for more than 3 months, or when the condition recurs twice or more often within a 12-month period of time. So this is important with regards to thinking about the time frame and chronicity of chronic eczema. And this definition is based on the European Society of Guidelines on Contact Dermatitis, which we'll refer to later as well in the talk. Now let's talk a little bit about the global prevalence of chronic hand dermatitis. And perhaps first, let us talk about the difference between point prevalence and lifetime prevalence. Point prevalence is a proportion of population that has a characteristic at a specific point in time, whereas lifetime prevalence is where we have a proportion of population where we calculate who at some point in their lifetime has ever developed that characteristic. So as a result, when we look at lifetime prevalence, it's typically a number that's larger than point prevalence. When we look at the global general population, depending on the region, the point prevalence of chronic hand eczema is anywhere between 2.7 to about 18%. And the lifetime prevalence ranges between 8.4 to 41.8%. When we look at the dermatology clinic population specifically, what we notice is that in adults, the point prevalence is between 5 to 48%, depending on the country that we're looking at. And the point prevalence in children in the population that we see in the derm clinics is between 19 to 26%. Here is a look at the various dermatology clinics across the globe, as well as the general population with regards to the prevalence. As you can see, in Australia, in the European dermatology clinics, we have a big prevalence that's there, and the range is also quite large as well. And in South America, it's relatively lower. North America, the point prevalence is anywhere between 18 to 47%. And then below the orange line is where we see the general population. As you can see, not surprisingly, when we look at the general population, the point prevalence is a little bit lower than that of the population that present to the general dermatology clinic. So here's a question for us. Do certain occupations put people more at risk for the development of CHE? And if we think about this particular question, and if you were faced with this multiple choice question, which of the following occupations has the highest lifetime prevalence of CHE in Europe, what would your answer be? Well, if you chose baker, you would be correct. So let's take a look at occupations and their relationship to CHE. So here is occupation-related lifetime prevalence of chronic hand eczema in Europe. As you can see, hairdressers typically rank very high with regards to their lifetime prevalence of CHE. And that particular prevalence can vary depending on the study. And you can see the range is actually pretty wide, anywhere between 8% lifetime prevalence to 44%. Following that, we have apprentice nurses, manual workers, and food handlers. So bakers, confectionery workers, as you can see here. Those are all occupations that can put people at higher risk of developing CHE. This chart shows the incidence of chronic hand eczema per 1,000 patient years. And as you can see here, again, not surprisingly, hairdressers rank the top, followed by butchers, bakers, kitchen workers, and then blacksmiths and mechanics, following that dental technicians, and then also healthcare workers. And then below is general population and a few other occupations. Now, when we think about the risk factors for the development of hand dermatitis, other than the occupations that we just spoke about that have been associated with higher prevalence of chronic hand eczema, let's think about other risk factors. And those include the following: previous episodes of hand dermatitis, a history of atopic dermatitis, a history of contact allergy, if you do wet work all the time, and also if the patient presents with early onset of hand dermatitis. Now, let's go on to talk about classification and etiology of CHE. Probably one of the key messages to remember is that there is a lack of consensus regarding chronic hand eczema classification and management at the global level. And classification systems can vary. Various groups can classify chronic hand eczema based on their location, or morphology, or etiology. So again, the key thing to remember is that there's really no current international consensus regarding the classification. So I'm going to go through a few ways we can think about classifying, and then later on we're really going to focus on the ESCD classification. So first, there are proposed location-based chronic hand eczema classification. For example, people have proposed distinguishing, for example, interdigital eczema versus pulpitis. So as you can see under this classification, this type of classification is really looking at where the specific lesions occur on patients' hands and then classifying patients accordingly. There are also suggestions of morphology-based chronic hand eczema classification. Here what we see are examples of hyperkeratotic palmar hand eczema. And what we know about this is that typically this type of hand eczema can be distinguished from psoriasis in that there are no typical nail changes that we can see in psoriasis involving the palmar plantar areas. Importantly, the hyperkeratotic palmar hand eczema typically affects middle-aged men. And now when we look at nummular eczema, this type of eczema oftentimes affects the dorsal aspects of the hands or fingers. Other specific morphologies that have been described with a chronic hand eczema include chronic fissured eczema, what we see on the left-hand side, and on the right-hand side where we can see these recurrent vesicular hand eczema, as you can see vesicles along the sides of the fingers as well as on the palmar areas. So here are some general considerations when we talk about classification and when you read about the various different classifications. One of the key things that one will realize is that oftentimes the pattern of dermatitis is polymorphic. And importantly, the morphology is unfortunately not at all related to etiology. And that can be a bit problematic. And in acute phases, typically erythema or vesiculations are predominant. And in chronic phase, fissures and hyperkeratosis is predominant. And some of the classification systems typically focus on etiology, and those can be oftentimes divided into irritant, allergic, or atopic. And the one example that I want to highlight, for example, is the Canadian hand dermatitis guidelines, where they highlight the 3 clinical types under chronic hand eczema as having irritant hand dermatitis, allergic hand dermatitis, or atopic hand dermatitis. But one thing that I wanted to focus on today, have us to go through it together, is a classification of hand eczema based on the European Society of Contact Dermatitis. And this is because this classification system has been used in a number of different settings and also highly cited in the literature. So when we look at this particular classification system, again, there's agreement. Some experts agree with this, and there are also disagreements regarding this as well. But let's take a look at this as a framework to think about classification of hand eczema into different categories. The two larger categories, as you can see here, are the exogenous hand eczema and the endogenous hand eczema. And under the exogenous hand eczema category are things like irritant hand dermatitis, allergic hand dermatitis, and contact urticaria or protein contact dermatitis. And they're classified under exogenous because exogenous materials oftentimes can play a large role in the pathogenesis of hand eczema here. The other larger category is the endogenous hand eczema, and these include atopic hand eczema, Pomfrix hand eczema, and hyperkeratotic hand eczema. So let's take a look at all of these 6 different categories of hand eczema. So under the larger umbrella of exogenous hand eczema, first we'll talk about irritant hand dermatitis. This is where hand dermatitis is due to prolonged or repeated exposure to primary irritants. And the diagnosis is based on 2 factors. Number 1 is a documented exposure to an irritant that's quantitatively likely to cause contact dermatitis, and one must show that there's an absence of the relevant contact allergen. So this is important. An example of the irritant hand dermatitis is really wet work. People who really are working in environments where their hands get wet quite a bit. Now let's go to allergic hand dermatitis. Allergic hand dermatitis typically is caused by delayed type reaction or type 4 reaction as an immunologic response to an allergen in a sensitized individual. Typically, for this diagnosis, one requires a positive patch test and a relevant current exposure to the allergen. And while the early lesions are at the site of allergen contact, but the spreading can occur at more distant sites as well. Again, it's very difficult oftentimes to distinguish between irritant and allergic hand eczema clinically or histologically. And now we're going to go to the third type, which is contact urticaria or protein contact dermatitis. Now, protein contact dermatitis is a more rare form and distinctive form of allergic or irritant hand eczema. As a result, it can be IgE mediated or even through non-immunologic mechanisms. It's called protein contact dermatitis because 4 groups of proteins can cause this entity. And these 4 groups of proteins include plant, animal, flower, or proteolytic enzymes. One of the examples is the natural latex rubber as a cause for protein contact dermatitis. Other examples include food allergens. And the diagnosis for this is typically based on exposure to the relevant proteins and a positive prick test. So again, this may be a result of combined type 1 and type 4 delayed hypersensitivity reaction. And there are also some non-immunological mechanisms that underlie its pathogenesis. Now we're going to the endogenous hand eczema category, and let's go to atopic hand eczema. Atopic hand eczema occurs in patients who have previous or current atopic dermatitis, and importantly, no documented exposure that could likely cause irritant contact dermatitis. Mutations in filaggrin are commonly seen in these patients, and they have a decreased epidermal barrier function. And in these patients, the cellular immunity may be also decreased as well. What about the next category? Now let's take a look at Pomfrix hand eczema. In Pomfrix hand eczema, it is considered an endogenous form of CHE with vesicular eruptions. And it's important to know that one must rule out any relevant contact allergies, and the person must not have documented irritant exposure that could potentially cause the hand dermatitis. Oftentimes, these patients develop these isolated vesicles on the palms of the hands or the sides of the fingers. And clinically, these vesicles can last 2 to 3 weeks and oftentimes resolve with desquamation. We want to avoid the use of the term dyshydrotic eczema because there's no really sweat gland involvement. So here are another examples of Pomfrix. As you can see, these tapioca-like or these vesicles on the sides of the fingers, and as you can see also on the palms of the hands. And now let's go to our last category, which is hyperkeratotic hand eczema, which I alluded to earlier when I talked about morphology and morphology-based classification. So in the hyperkeratotic hand eczema, in this particular classification system, as you can see, chronic hand eczema presenting with hyperkeratosis in the palmar hands or pulpitis as well. Important, the patients must not have documented irritant exposure. Oftentimes in these patients, the causative factor or the causative agent is unknown. And these patients oftentimes, interestingly, do not present with concurrent vesicles. So as you can see, we reviewed the ESCD guidelines for classification of CHE, and there's a subsequent paper by IEC counselors talking about some of the agreements and disagreements with regards to their reactions to the guidelines and how we can potentially all come together and think about where the gaps are in terms of research as well as consensus. And so with that, I want to thank you for your attention.
Hello, and welcome to this 10-minute lecture on how to run a hand eczema clinic. My name is Tove Agne, and I'm a professor at the University of Copenhagen. And these are my conflicts of interest. So now setting the stage for hand eczema. Hand eczema is a frequent disease with a one-year prevalence of up to 10%. It's often occupational. It often takes a chronic course, and patients with hand eczema have a significantly decreased quality of life. And the disease often starts in the young age groups. So, of course, efficient treatment and prevention is needed for this disease. On the next slide here, you can see the distribution of hand eczema with respect to sex and age. And this is data from 10 different European clinics. And what is interesting here is that you can see in the younger age groups in particular, there are much more females than males among the patients. And hand eczema is a disease that affects patients from 20 years of age and up to 60 years of age, and becomes much more rare in the older age groups. And here are the different subdiagnoses and distribution, again, from the same group of hand eczema patients from 10 different European clinics. And what you can see here is that the exogenous types of hand eczema, like irritant contact dermatitis and allergic contact dermatitis, they comprise much more than half of all cases of hand eczema. Then we have the atopic hand eczema comprising around 15% of all cases. And we also have the endogenous types of hand eczema, like the hyperkeratotic hand eczema and the acute recurrent vesicular types of hand eczema, and both comprising less than 10% of all cases of hand eczema. It is important for you and for the patient to reach a correct subdiagnosis for the patient, because then it will be more easy to give a precise advice to the patient on behavior, and also will be a more easy to choose the correct treatment for the patient. So the objectives for the medical consultation for hand eczema patients will be to do an efficient medical workup. It will, of course, be treatment of the acute eczema, but also planning the long-term treatment, which is more challenging than the acute treatment. Patient education is an important part with respect to increasing knowledge about skincare, and also maybe when needed, change of behavior. And it's also important to provide some preventive strategies to the patient. And everything should, if possible, be evidence-based. So in the ideal world, I would like to see my hand eczema patients at 3 consultations. And the first consultation will, of course, comprise medical history, some medical investigations like patch testing, and then treatment of acute eczema. The second consultation, which can be up to 3 months later, will focus at having the specific diagnosis clear for the patient so that we know the specific diagnosis. We would like to do some treatment modification and maybe start some systemic treatment. And the third consultation will be in most cases just kind of a check-up and maybe optimizing the treatment for the patient. But let's look a little bit more in detail into the different consultations. So with respect to the first consultation, the medical history is very important. We should know whether the patient has atopic dermatitis, any atopic dermatitis in the family, and the same with respect to psoriasis. And we would also like to have an idea about exposures, which exposures are relevant to look more into at home and particularly also at the working place. And when we investigate the exposures at the workplace, it's sometimes very helpful to have the patient to use a mobile phone, because then you can very quickly and easily get an idea what's actually going on at the workplace. So this is sometimes a big help. At the first consultation, we'll also do a patch test, and here we'll of course include the baseline series, but also specific work-related series, and sometimes also own products. Maybe you'd like to include a severity assessment. I find it very helpful in my clinic, and it could either be a quality of life assessment, like a questionnaire the patient can respond to, or it could be a scoring system. We have the HEXI, Hand Eczema Severity Score Index, useful for assessment of severity of hand eczema, just like we have the PASI score for psoriasis and we have the EASI score for atopic dermatitis. Then we can use the HEXI for severity assessment of hand eczema. And it's a good basis, you know how it was at the start, and then we can follow up later on changes in the HEXI score. At the first consultation, it's also recommended to include patient education. And in my clinic, we do it like a 20-minute guided talk given by a nurse. And it includes advice on hand eczema, like use of emollients, substitution of hand wash with disinfectants, some advice about use of gloves, of course, recommending not to use finger rings, and also some more specific advice on occupational exposures when that is relevant. At the first consultation, we will aim at treating the acute eczema if there is an acute flare, and we will give some instructions for how to use topical corticosteroids. Many of our patients have, of course, already used topical corticosteroids for quite a while, but some of them are using it incorrectly, and instructions are important. And sometimes we will also have our nurses to demonstrate the use of topical corticosteroids. We will give some information for the patient about proactive treatment using topical corticosteroids twice weekly. And sometimes we can introduce either tacrolimus or UV treatment when necessary. And we can, in the severe cases, prepare for systemic therapy. We can talk systemic therapy over with the patient and give them some idea what this actually is. And we can also sometimes take some blood samples to make ready for start of systemic therapy. And then up to 3 months later, we'll have the second consultation. And here we can discuss the result of the patch test. And that's important to take your time there and determine the relevance for each positive patch test reaction. and to give the patient oral and also written information about the patch test results. We find it quite practical here to use durable small cards in plastic so that the patient can keep these cards and have them also years later so they know what they were actually allergic to if there are any positive patch tests. And at the second consultation, we will be ready to make the sub-diagnosis, or in some cases, the patient will have maybe up to 2 or more sub-diagnoses. But it's important to have a more specific idea about the sub-diagnosis of this hand eczema. It makes it possible that the patient can actually do more themselves to optimize the situation when they understand what the etiology for the hand eczema is, and it also makes it easier for the doctor to give the correct advices for the patient. We can also again make assessment of severity using either quality of life or the HEXI scoring system, and we can optimize the topical treatment, talk it over with the patient, maybe start some systemic treatment. And treatment available today for chronic hand eczema is, of course, topical treatments. It is physical treatments with UV, and there's a number of systemic treatments. And I should mention that actually none of these treatments are actually licensed for treatment of chronic hand eczema, but it is the treatments that are traditionally used. And luckily, we have a lot of new topical and also systemic treatments emerging, and that's a very good situation. However, it's not the topic for this talk. It's also important to discuss lifestyle factors with your patient, because we know from new literature that there's a very strong association between smoking and severe hand eczema. So, and there are also new results from studies indicating that the stress and also lack of physical activity is associated with severe hand eczema. So in my clinic, we have decided to include information of stop of tobacco smoking and advices about that for our hand eczema patients. The third consultation, which can be up to 6 months after the first visit, should be easy if things have worked out well for the patient. Then we can make an assessment of severity, which should hopefully be improved as compared to the first and the second consultation. We can focus now on treatment if the patient is satisfied, or is a change of therapy needed? Are there any side effects to the treatment that we should focus on here? And sometimes it is a good idea to ask the patient about the education. What do they know about treatment of hand eczema, and is it indicated to repeat the patient education? Then we can do it again. So in conclusion, fixed programs for hand eczema patients ensure that all patients are offered a full diagnostic workup, and follow up with severity assessment is a good quality control for yourself to ensure that the patient has actually improved. And then I would like to underline the importance of patient education. And thank you so much for your attention.
Thank you all for the opportunity to address you on a vexing clinical issue that we all see in the office, hand dermatitis, and specifically allergic contact dermatitis. These are my disclosures. I work with a number of companies in this space, and I will also be discussing non-FDA approved patch test allergens. Hand dermatitis, as you already heard, is a very broad diagnosis that encompasses many different types of pathophysiologies and diagnostic areas. You've already heard in prior lectures about the epidemiology, and I would just call out here that there are many potential provocateurs of contact dermatitis as it relates to the hands. They may be exogenous, like irritant and allergic contact dermatitis, often interplaying with endogenous causes like psoriasiform dermatitis and atopic dermatitis. Most often we're seeing hybrids in the office, and the spectrum of these diseases can range from acute vesicular contact dermatitis with erosions to hyperkeratotic and fissured lesions. There is some data suggesting that hand psoriasis may have higher frequencies of positive patch tests. For those patients referred for patch testing for a suspicion of allergic contact dermatitis, hand involvement leads the list as the singular body part involved. Consequently, when we're seeing a hand dermatitis that has an eczematous component, we might think of patch testing them. We see other areas involved, and also when we're talking about the hands, we also consider the feet. Now, as mentioned before, these polarized textbook diagnoses of hand dermatitis, either eczematous or psoriasiform, they're largely elusive. The reality is we're faced with the diagnostic quandary of either picking the best diagnosis based on comorbid diseases and involvement in more classical areas, right? Pick one of these. Rarely will a biopsy give us the perfect diagnosis here. I mentioned before that there are a number of risk factors, atopic dermatitis being one of the most important one. And I think this is a very illustrative case of an atopic patient presenting to me with all the attendant diatheses for atopic dermatitis, her clinical picture being rather mild to moderate disease with involvement in the antecubital fossae, a little bit on the neck, and of course that stubborn finger involving her hands. And I was quite surprised that her patch tests were as revealing, seeing here many reactions to preservatives and metals, and more importantly, avoidance of them resulting in her near clearance after years of using topical corticosteroids here. One other additional item is the COVID pandemic, which presented additional therapeutic and diagnostic quandaries for us, healthcare workers and nearly every person in the world donning personal protective equipment on their hands and their face. And we see irritant and allergic contact dermatitis in these areas. This patient, my daughter, a COVID ICU nurse at the time, presenting with irritant dermatitis of her face and hands. In this North American study, patients with hand eczema demonstrated an elevated rate of positive patch tests. So with this hand eczema, their chances of having positive patch tests to common allergens like methyl isothiazolinone, nickel, formaldehyde, quaternium-15, and fragrance were seen. Recent data from just a number of weeks ago evaluated children. About 14.5% of pediatric patients presenting for patch testing had hand involvement. Ultimately, half of them had a diagnosis of allergic contact dermatitis rendered, while about a third atopic and 16% irritant. Here again, we see common patch test allergens causing dermatitis on the hands commonly. MI, the glycols, the surfactants, the desylglucoside, and items used in emollients like lanolin. So if we look at large epidemiologic trials, what do we see as far as contact dermatitis? In this study of the general population of Danish people, a history of atopic dermatitis was associated with a considerable risk factor for allergic contact dermatitis in those with persistent or incident hand dermatitis. Fragrances and the isothiazolinones were important allergens noted in this study. For healthcare workers, we represent a rather high-risk population for hand eczema. Most are diagnosed with irritant contact dermatitis, but allergic contact dermatitis is not that uncommon, with rubber chemicals, not surprisingly, most often from gloves, preservatives, and excipients in hand cleansers. If we sort of pivot off some of the usual areas we think about and go into our occupational clinics, not surprising that mechanics are a group that suffer from hand dermatitis. Still in these days, males outnumber females in those presenting for patch testing who are mechanics. And again, hands are often involved with allergens like carbamates, thiorams, and preservatives. And these come from things like gloves, solvents, oil and cooling fluids, and lubricants, as we might expect. Now, we've heard rubber a number of times, particularly from personal protective equipment. This is a thoracic surgeon that I've seen who would routinely self-treat with prednisone when he was on call, always had these eroded plaques, and this, not surprising to most of you, a back full of positive patch tests, mostly but not exclusively to rubber accelerating chemicals. And avoiding those resulted in really amazing improvement in his eruption. So rubber, an important hand dermatitis allergen, fall into 5 main allergen categories: the thiorams, the dithiocarbamates, the benzothiazoles, the guanidines like diphenylguanidine, and the thioureas, like we see in neoprene rubber. Of late, we're seeing carbamates being used far more in gloves than thiorams were, where that used to be sort of the lead allergen. And patients who were evaluated in North America over a multi-decade period, almost 50,000 patients, a number of them tested positive to rubber, over almost 7%. I think that's a pretty high number. Men, occupational related contact dermatitis, and hands were risk factors for having positive reactions to the rubber accelerators. And when these accelerators were positive, they were considered clinically relevant. And again, gloves were our most common source. So the question at hand, I think, for just a thought experiment, is whether the pandemic, replete with the global use of PPE, including lots of gloves, could translate into a second wave of rubber contact dermatitis in epidemic form in years to come. I have an arrow pointing here to the mid-1980s, where we saw a rather stable activity of thiorams and carbamates, which go back to the 1940s, sharply increasing in epidemic form, coincident in the US with the Centers for Disease Control issuing universal precautions, and then in 1987, additional guidelines called body substance isolation, which advocated for the avoidance of direct physical contact with moist and potentially infectious body substances. All of a sudden, glove use increased, and the prevalence of positive patch tests to rubber chemicals also increased in parallel. We figured it out in generally or throughout the world, and it's stabilized. And this is just food for thought whether we'll see a second wave. I mentioned the isothiazolones quite a bit, and this is an international conference, and we saw epidemic rise of the prevalence of methyl isothiazolone across the world, different countries and areas dealing with it differently. But I want to point out that testing with the MCI-MI Cathon patch test will probably render a lot of false negatives. Patch testing to higher concentration, about 0.2%, is necessary. And we note that our European colleagues, being very quick on recognizing this and doing something about it, banning it largely in leave-on products, has resulted in a major reduction in the prevalence of positive patch tests and contact dermatitis to isothiazolones. We see them widely in our industrial uses, and for example, nearly all water-based paints contain methyl isothiazolone. And here's in case a patient with recalcitrant hand dermatitis, patch tested to a standard series. Notice the yellow on the upper left. negative to the 100 parts per million of the MCI-MI, but positive to the 2,000 parts per million on the lower right. And in fact, this hand emollients, cleansers, and surface cleansers that were being used in their workplace. I mentioned fragrances a little bit earlier as a recurrent theme, as important items in hand dermatitis. Fragrances are remarkably common during patch testing. More than 1 in 5 people who we patch test to a large enough number of fragrances react to them in botanical extracts. They're common in women on the face, legs, and anogenital area, but hands as well. The reason these are complicated is they're so ubiquitous. There are thousands of fragrance chemicals available for use in personal care products, and the sensibilities of what smell good tend to change with time. Now we're seeing commonly chemicals like linalool and limonene, particularly in their oxidized form, lyral, and natural extracts like tree moss and oak moss being common fragrance allergens. Cleansers are complex items that constantly touch the hands and can frequently cause hand and arm dermatitis. There's a large number of allergens in cleansers that can do it, namely the surfactants, the preservatives, and the fragrances. And I would just call out in 2017, the alkyl glucosides were named Allergen of the Year by the American Contact Dermatitis Society. Here, a patient of mine reacting to amidoamine or cocamidopropylbetaine from a cleanser that they repeatedly used on their hands. And lastly, one kind of interesting and difficult to diagnose issue. This patient presented to me with fingertip dermatitis and some dermatitis on the palmar surfaces. She came up positive to nickel, felt that foods were very important and provocative, particularly soy-based and chocolate parts of her diet would make her worse if she ate a lot of it, which makes us think of systemic allergic contact dermatitis. Of course, non-contact exposures through parenteral routes, through oral, intravenous, other GI or injectable routes, and nickel often described as a provocateur for dyshydrosiform hand dermatitis when the diet is high in nickel. So just to conclude, the allergens that cause hand allergic contact dermatitis still are our most common allergens that cause contact dermatitis in other sites, right? We see the metals listed in the top 20, the preservatives, the fragrances, and the rubber chemicals all listed very high in the most recent North American contact dermatitis study. So to conclude, hand dermatitis, very heterogeneous group. You're going to hear that throughout the whole symposium today. Treatment rests in trying to detect the provocative causes that may make this hand dermatitis worse or recalcitrant to disease. Even corticosteroids that we use as treatment may be the source of the allergens. But patch testing is an important tool and one we ought to consider frequently when we have patients with difficult to treat and moderate to severe hand dermatitis that can perhaps give us some insight into the cause of their dermatitis. Thank you so much for your kind attention.
My name is Robert Bissonnette. I'm a dermatologist based in Montreal, Canada, who has had a long-standing interest in chronic hand eczema. This is my disclosure slide. Hand eczema severity. This is an issue that right now is becoming more and more important. It is something we're more and more interested in because there are more and more drugs currently being developed for the treatment of chronic hand eczema. However, this publication, which dates back now to about 11 years, looked at articles that were published with methods to quantify hand eczema. What they found was up to 2009, out of 69 articles, there were 45 different methods used. If we would do the same today, we would probably find similar issues. There's a lack of good standardized measures, validated measures that are part of a core outcome that is used in every trial in chronic hand eczema. There are some good measures, and I'll review some of them with you, but there's really a need to try to standardize what we use in the various trials. One of the reasons why I think this is happening is that in the US, we have no drug that is currently approved to treat chronic hand eczema, and we have very few that have been approved ex-US. So on the bright side, in my opinion, hand eczema is easier to evaluate in terms of severity, easier than atopic dermatitis. Lesions are located on hands only. This is what we measure. There is no interference with hair, clothing, folds in obese patients, less lighting effect. However, morphology can be fairly different for palms and the back of hands. In addition, there's a higher diversity, if one could say, of lesion type as compared to atopic dermatitis. These are the main measures I'll be reviewing with you today. One measure I won't be talking about, but it's a very important measure, is pain and pruritus NRS. So the typical scale that is used nowadays is a 10 grade from 0 to 10, NRS or 11 grade, to measure pruritus and pain. This is very, very important, specifically pain for chronic hand eczema. I won't talk about it because it's fairly standard and well known by most people doing research or seeing patients in that area. PGA, IGA, big issue. This is the PGA scale that was used in the studies that led to approval of valetretinoin. This is an interesting PGA scale that combines both severity of lesions, you can see, to area of involvement, to symptoms, because we also measure pruritus and pain. The issue is that this PGA scale cannot be used in phase 3 to get approval of a drug in the US because it, one, combines signs and symptoms. 2, it's very focused on area. And 3, the various grades don't have a specific descriptors for each of them. There's an issue in terms of IgA and PGA to evaluate chronic hand eczema because there's currently no validated good IgA or PGA scale that will be amenable to be used as a primary endpoint in phase 3. This is changing. As you know, many drugs are currently in development for chronic hand eczema, and there are scales that are currently being developed and validated. So in the next 2 years, we'll probably see a number of those published validated scales. And these are the ones that will probably be used in phase 3. One thing that is interesting about PGA for hand dermatitis is it's fairly easy to take photos in order to create photonumeric scales like this one. HEXI, or Hand Eczema Severity Index. This is the most widely used scale to evaluate chronic hand eczema. It evaluates 5 different areas: fingertips, fingers, palm, back of hands, and wrists. 6 signs are evaluated on a scale of 0 to 4, and surface is evaluated as well. This is typically a grid to evaluate HEXI. It's a bit reminiscent of EASI and PASI, where we have the areas, the different signs, and then the area involved that you also need to select. Very interesting tool. Gives a lot of information on the severity and the location of severity for a given patient. In my experience, it takes a little while for a dermatologist or an evaluator to really feel comfortable using the tool. But once you're comfortable, I think it's very good. One drawback of this tool and most of the EASI and PASI tools is that it's not that sensitive for patients with limited body surface area involvement. And if I can draw your attention to the fact that in order to go from 1 to 2 in the extent, you need to have an area involved with hand eczema of more than 25%. Validation has been done with this scale. There's been an effort to look at intra-observer differences. On this slide, you can see that the ICC for inter-observer variation was very good, usually higher than 0.8. For intra-observer, we can also see that there's a very good correlation in terms of patient evaluation. MTLSS, or Modified Total Lesion Symptom Score. MTLSS has been used in phase 3 trials with valetretinoin. It has not gone through extensive validation like HEXI, It's very different from XC and IgA PGA because it's the evaluation of only one area of one hand. So in order to do MTLSS, the investigator needs to select the most affected side of the most affected hand. It's more a target lesion type of evaluation. What is evaluation? What is evaluated? You can see on this grid, erythema, scaling, lichenification, vesicles, edema, fissures, but also pruritus and pain. So it's a combination of signs and symptoms. Again, this could not be used as a primary endpoint in phase 3 studies. One thing that I like about this scale is that it provides clear descriptors for the various severity parameters, and it's fairly easy to use by investigators that are starting to do trials in chronic hand eczema. This, I think, is an interesting endpoint in smaller proof of concept studies. Could be added in phase 2b and 3 as well. Hand eczema extent score, a different scale that is looking at extent. So this scale really provides a lot of granular information on where the lesions are located. You can see on this figure. The way this is done, the evaluator needs to look for thumb, index, middle finger, ring, little finger, and indicate if yes or no, there's involvement of chronic hand eczema on all those areas, back of finger, side of finger, underside, etc. So it provides interesting information, specifically if combined with Hexi, to try to get a good idea of what the patients are when they start the study in terms of severity and how it evolves over time. Some validation has been done. On this graph, you can see that patients can also use this, and even though there's no perfect correlation with dermatologist evaluation, it's not so bad. There's been some validation in terms of intra and inter-observer reliability, and ICCs are fairly good. Quality of life, so quality of life and eczema questionnaire. This is developed in Germany, validated in several other languages, but some of the major languages, from what I know, still have not been validated. The questionnaire has not been validated, for example, in French. It is specific for hand eczema. It assesses hand specific quality of life over the past 7 days, 30 items, 5-point NRS, and it measures, as you can see on this slide, symptoms, emotions, functioning, and treatment prevention. Validation has been done. It correlates with the LQI, correlates with other severity measures like PGA, a good test-retest reliability. The LQI, as all of you know, this is the most widely used questionnaire or quality of life questionnaire in dermatology, translated in more than 100 languages. This study looked at correlating the LQI questions to severity of hand dermatitis that is measured by the investigator, and some questions correlate very well, like pain and pruritus, shopping. Others, there were no correlation, like clothes worn or problem associated with treatment of skin. And interestingly, there was no correlation in this validation study with impairment of sporting activities. Finally, BOHEM, New Kid on the Block. It's a new questionnaire looking at burden of hand eczema. Validation has been performed for French and English. It is a questionnaire with 15 different questions. You have a list on this publication, and this is slowly starting to be used in clinical research. So in conclusion, there's really a need for a validated PGA, IgA tool that could be used in phase 2 and 3 studies for regulatory purposes. Lesion severity, XC, MTLSS, and HEAS provide different informations. Quality of life, QOL-HEQ, and the LQI being the ones most extensively used, and BOEM being the new kid on the block. Thank you.
Welcome, everybody. I will be discussing current therapeutic strategies for phototherapy and systemic therapy. These are my disclosures. None of these really should be relevant to what we'll be discussing today, although may be relevant overall. I will try to present a fair and balanced presentation. So let's start off with phototherapy. And really to frame this conversation and really the next few slides, we are fortunate to have a recent Cochrane systematic review that was performed that really assessed the level of evidence that we have to support the efficacy for various interventions in hand eczema. And this is just a small part of one of the tables in that manuscript, examining, the studies out there for phototherapy, particularly with ultraviolet B as a modality versus either different study designs, either placebo or versus topical PUVA. And we have some varied results, but when looking at investigators' assessment of good or excellent control, we have multiple studies that have shown significant improvements for local UVB therapy versus placebo, versus whole body plus hand UVB, and even versus topical PUVA, although with a smaller effect size. So we have a demonstration of efficacy for ultraviolet B light. We also do have a demonstration of efficacy for topical PUVA and other light modalities. And often the choice of modality will really vary by region in terms of which devices are available and what is considered sort of normative use in different regions. With respect to oral interventions, really the go-to agent for many clinicians around the world, and I'm sorry to say it's not, unfortunately, not my go-to agent because I don't have access to it, but for many regions around the world is alitretinoin. And we have some pretty good evidence that alitretinoin is effective in hand eczema in a dose-dependent fashion. Looking at the 10 milligram dose, we have several studies showing that there's improvements in terms of investigator-rated symptom control compared with placebo. Not necessarily an enormous effect size, but number needed for treatment benefit for 11 patients over topical therapy. And then also significant improvements in subjective outcomes or patient-reported outcomes in terms of symptom control. And we see an even stronger effect size when we look at the alitretinoin 30 milligram dose compared to placebo, where the number needed for treatment benefit over topicals would be 4, and we have a larger effect size in terms of relative risk for improvement. And this evidence was rated as high certainty. Now, there are adverse events, but overall well tolerated, but the number of adverse events, including headache, in this case was rated as probably not differing between alitretinoin 10 milligram and placebo, but the risk of headache increased with alitretinoin dosed at the 30 milligram, and that was felt to be a high certainty of evidence. So we see a little bit of an increase in adverse events, but overall a demonstration of good efficacy. Now, cyclosporin is an option that we are certainly familiar with across many inflammatory disorders, certainly in atopic dermatitis. And we know that dose matters, but there are studies that have examined oral cyclosporin A at a 3 milligram per kilogram daily dose and found that cyclosporin probably slightly improves investigator-rated control of symptoms and participant-rated control of symptoms. We don't have an enormous amount of studies here, and this was compared to the background of topical betamethasone after 6 weeks of treatment. And we certainly do see an increase in risk of adverse events, dizziness, and of course, there's a well-established side effect profile for cyclosporin. And in this case, the evidence was rated as moderate certainty of evidence. So those are sort of the options that could be voted on or rated in a sense in terms of the level of evidence because there were enough studies. After that, many of the studies really come down to retrospective or case control or a case series and things like that, but not really necessarily controlled studies. So how do we put this together with the level of evidence that we have and what we know about existing therapies for atopic dermatitis? And there are a variety of different guidelines that have been developed over the years for how to use therapies in general or systemic therapy in particular for hand eczema. This is one of the earlier guidelines developed. This is a consensus guideline, including a panel of dermatologists and a general practitioner who had a special interest in dermatology. And you can see this flow chart on the right. It is a complicated figure, but I want to draw your attention particularly to the rightmost panel along the edge and really going to the lower part of that. Thinking about, in that rapid control category, cyclosporin or oral steroids may fit into that. We know that those are agents that tend to work quite quickly, but unfortunately are often quick fixes and aren't great for long-term management. When we get into hyperkeratotic or vesicular hand eczema, topical PUVA is an option. Cyclosporin again could be potentially used. And here we see alitretinoin appearing as well And then for hyperkeratotic, this particular guidelines recommended acitretin. We do see a little bit less efficacy of alitretinoin in that hyperkeratotic subgroup. I'm not sure acitretin is all that much better. It may just be a tougher to treat subset in general. And then here, other agents like methotrexate and mycophenolate are positioned as sort of second line or last ditch efforts if one has already failed alitretinoin or cyclosporin, etc. Other guidelines have been developed, and the German Dermatologic Society guidelines and Canadian guidelines recommend the use of high potency topical corticosteroids, ultraviolet therapy, and again, alitretinoin as that recommended treatment approach. And then as a last resort, other systemic treatments such as cyclosporin. Now, in terms of the US experience and my own sort of anecdotal personal experience with systemic therapy for hand eczema, we don't have formal guidelines for hand eczema in the US. Narrow band ultraviolet B is generally the predominant modality of phototherapy available. It is often considered to have a better safety and tolerability than PUVA, but it is a relatively slow onset of efficacy, which is leaves important unmet needs, and often is inadequate in terms of the efficacy for patients. The biggest challenge, of course, with phototherapy in general, but certainly in the United States, is just access. Is so limited for so many patients. There's not enough phototherapy sites. The hours are limited. It's hard for patients who work or caregivers. We very unfortunately do not have alitretinoin approved in the United States. And so when we think about all of the published guidelines leaning so heavily on alitretinoin as a go-to option, that is unfortunately not our reality in the US. The cyclosporin, of course, works well short-term, but generally should not be used for long-term maintenance. I find that it often requires even higher doses than 3 milligram per kilogram just as a starting dose in tougher cases of hand eczema. And of course, we know the challenges of safety, tolerability, and laboratory monitoring. Anecdotally, I happen to like using methotrexate very much. I kind of lean on methotrexate the way maybe the rest of the world would lean on alitretinoin. Often requires higher doses though, and often is inadequate efficacy, and particularly for profound xerosis and that hyperkeratotic subset. And really, as a close, now more and more we're starting to use dupilumab, off-label, in some cases this is on-label for hand eczema in the context of more generalized atopic dermatitis, and we see good results. And then perhaps more off-label, if you will, for isolated hand eczema. And with that, I think you'll hear a lot more about dupilumab, particularly for hand eczema, in the next talk from Dr. Gutman. And so with that, I would like to thank you for your attention, and I hope you enjoy the rest of the seminar.
Hi, everyone. I'm excited to give this talk on new topical and systemic treatments for chronic hand eczema. Finally, an exciting times for chronic hand eczema. And we all know that we needed these treatments desperately. So first, my disclosures. I don't have any patents, ownership, or financial gain from any atopic dermatitis or chronic hand eczema product that is going now into the clinic. So just to review, how did we get to this point of therapeutic development in atopic dermatitis and also in psoriasis? This was possible through bench studies of pathogenesis with biomarkers that led to clinical trials with targeted agents that also had biomarkers of treatment response. And after multiple cycles, we got this amazing therapeutic development that we are experiencing now in both psoriasis, but also in atopic dermatitis. And both the successes, but also the failures, really helped us frame the pathogenic concepts and the therapeutic directions we are going. So what about chronic hand eczema? We need to remember that biopsies are a little bit tough to do in hand eczema because it's not an area that we can do multiple biopsies. And we really need biomarker studies to really understand the pathogenesis of chronic hand eczema. But I think we have a solution using tape strips in order to quantify biomarkers for irritant and allergic contact dermatitis and atopic dermatitis associated with chronic hand eczema. So now we are going to talk about emerging topical and systemic treatments for chronic hand eczema. And of course, I will start with JAK inhibitors, very busy time for JAK inhibitors for multiple skin indications, but particularly for atopic dermatitis and chronic hand eczema. And why JAK inhibitors are very well positioned to treat chronic hand eczema. The reason being that chronic hand eczema is a hodgepodge of several cytokine pathways, and these include Th1, Th2, and Th17, really depending on the etiopathogenesis of the chronic hand eczema, whether it's atopic chronic hand eczema, whether it's irritant contact dermatitis, or allergic contact dermatitis. So irritant contact dermatitis involves Th1 and Th17 pathways. Allergic contact dermatitis depends on the allergen, but it's either Th1, Th17, or Th2 and Th22. And atopic dermatitis is Th2 and Th22. So thus, for effective therapeutic response in the majority of patients with chronic hand eczema, we really need to target more than one cytokine pathway. And this is what we have with JAK inhibitors, such as JAK1 that targets multiple of these cytokines that are needed here to target. And we have additional cytokine targeting from the JAK2, JAK3, or TYK2 targeting. So this is really important to remember. The first study that I want to present is a phase 2A randomized vehicle-controlled, double-blind, placebo-controlled trial of topical delgocitinib for adults with chronic hand eczema. And delgocitinib is a pan-JAK inhibitor that inhibits both JAK1, JAK2, JAK3, and TYK2. And again, it will basically handle the immune abnormalities that involve chronic hand eczema across the different phenotypes, whether it's irritant contact dermatitis, allergic contact dermatitis, or atopic hand eczema. And this study involved adults between 18 to 65. It was an 8-week treatment of delgocitinib ointment, 0.3% BID as compared to vehicle. And it looked at PGA and HEXI. And these are the data. It was not a large study. It was relatively a small study. And here we see really nice data in terms of the PGA for chronic hand eczema, PGA 0.1, and more than 2-point improvement from baseline. But not so good results in HEXI. HEXI is a little bit more controversial for using clinical trials. And I think I would advise more to use PGA and MTLSS that are used in multiple studies rather than HEXI that is much more cumbersome and harder to use. In this study also, there were some signal of nasopharyngitis and headache, so some systemic exposure likely, but there were no AEs that led to study discontinuation in the delgocitinib group. So for sure, we need additional studies to understand systemic absorption. Now, another study was the DREAM study, phase 2B randomized, again, double-blind, vehicle-controlled study of delgocitinib cream in adults with chronic hand eczema. Here, multiple doses went forward for a 16-week period this time. And you see that there were a little bit differences between males and females, but overall, I think the study was balanced and a broad range of severity here, as you can see, again, adults. And here you see actually, and here it was the HEXI. You do see a nice dose response in the HEXI, and also in the IgA, you see a nice dose response with both of the highest doses achieving a significant success at week 16 in the chronic hand eczema IgA. So generally, really nice responses with success as compared to vehicle. Vehicle, as you see in terms of IgA, very low responses. And as you know, this drug is moving forward in patients with chronic hand eczema. What about oral treatments? We know that for some patients, they may need oral treatment, and there is a drug that addresses that, gusacitinib from Asana, That's a JAK-TYK inhibitor, so it's also a pan-JAK and TYK inhibitor. Due to that, it will inhibit Th1, Th2, Th22, and IL-23 signaling. And this study was a 16-week study with a follow-up. And we see here a nice dose response between the 80, 40, and placebo with significance achieved at multiple weeks here in the primary endpoint. And the primary endpoint here was reduction in MTLSS, that's a composite score, with gusasitinib. And the PGA 0/1, again, a very nice dose response. This is what we want to see in these studies. And pay attention to the low responses in placebo in chronic hand eczema. So these are refractory patients that probably used multiple other studies or multiple other drugs. In terms of safety, so overall, there were asymptomatic CPK elevations, no changes in total cholesterol, though there were increases in HDL and decreases in LDL, and no significant changes in hematology lab assessments, no opportunistic infections, thromboembolic events, MACE, malignancies, or deaths. But we do see some GI manifestations, as you see, vomiting, diarrhea, and some upper respiratory tract infections, as we see with other JAKs. So we do see those signaling. And considering its mechanism of action, I think it will be important to fully understand the risk-benefit profile of this drug in future studies. The drug also is moving forward now to phase 3. What about dupilumab? Dupilumab is used in practice for a chronic hand eczema, and also there is a study with dupilumab for chronic hand eczema. Why would it work? Because it decreases Th2. Indirectly, it has effects in decreasing Th17 and Th22. And it works on differentiation that is also involved in chronic hand eczema, so likely should work. Again, there is a study ongoing that we do not have results from, but it's in clinicaltrial.gov. But in real life, we are all using it. And this is a patient from my own practice, very refractory patient. And dupilumab worked really well in this patient, and many others. We also see that it works with this hydrotic eczema, a type of chronic hand eczema as well. So this is before and after in this patient. And this is the on the feet. So both hands and feet. What about other treatments? Apremilast, for example, is being used by some people for chronic hand eczema. And there is some efficacy, particularly for those patients that have irritant or allergic contact dermatitis, where Th1 and Th17 are involved. There was a pilot study listed in clinicaltrial.gov of 10 patients that were to be treated with the 30 milligram BID dose as a single arm for 6 months. But the study was terminated early because the PI left George Washington University. So that will not go on for now. Future directions for hand eczema, we really need to incorporate non-invasive biomarkers, particularly tape strips, in clinical trials to help shed light into the phenotypes of the different chronic hand eczema phenotypes. And we are actually involved in such a study that we hope will really shed light into the pathogenesis so that we'll have new treatments. So thank you so much. And I hope you'll share my excitement, because we really are beginning an exciting medical and scientific path for a new treatment paradigm for our patients with chronic hand eczema that are in dire need of better treatments. Thank you.
So thank you very much to all the presenters. This was a very interesting session. I can see that it was a very well-attended session as well, more than 116 people still present. We have received a few questions And I will try to ask one question to every person who presented. Unfortunately, we have only 11 minutes, so I'll start with Dr. Armstrong. Somebody wanted to know if you differentiate Pemphigus from vesicular endogenous hand eczema, and maybe you can comment as well if you pursue allergic testing more in these patients than other patients with chronic hand eczema.
Great. Thanks for our question from our colleagues from Rady's Children's Hospital, San Diego, which is south of me. So the umbrella term that's typically considered is the vesicular hand eczema. And the vesicular hand eczema term typically encompasses endogenous and exogenous origins, which can be allergic or irritant contact. And based on the European guidelines, Pemphigus should be a term that's only reserved for the endogenous form of vesicular hand eczema. So to that question, Pemphigus would be considered the same as the vesicular endogenous hand eczema. And to whether we pursue testing with regards to patch testing more aggressively for these patients, I think that oftentimes when the pictures are unclear, and as Dr. Cohen said, it can be quite heterogeneous, I would pursue patch testing in many of my patients with Pemphigus.
Very good. Thank you very much. A question for Dr. Agner. Somebody wanted to know what you suggest for patients who have fissures on fingertips or joints, which, as we know, is very painful and very difficult to treat. I think you're muted.
Sorry, yes. It's a challenge, of course, to treat these fissures, and I think the treatment doesn't necessarily differ from ordinary treatment of hand eczema, but we would proceed to systemic therapy quite quickly in these patients. And as a practical measure, maybe add some hydrocolloid bandages, but of course it is difficult to use them on the hands, but it could be a helpful trick. But I think the trick is also to proceed to systemic therapy.
Very good. Thank you very much. A question for Dr. Cohen about nickel allergy. So you mentioned the in patients with vesicular hand eczema, there's an association with nickel allergy. Is this something you often see in your practice? And have you been successful when you find a positive patch test, either we're using diet, avoidance to improve those patients? Is this something that we should really try to pursue or not?
I think it's a great question, and it's not an easy one. It doesn't happen often, but if you have someone with chronic, persistent, recalcitrant hand dermatitis that you've patch tested, and you have a robust positive patch test to nickel, say a 2 or 3+, first steps, get the patient a dimethylglyoxine test and have them do everything they can to avoid contact with the metal. If after 6 or 8 weeks, there's a failure of that typical avoidance protocol, and you've avoided all the other allergens, I do provide a diet that describes high and low content foods with nickel in them. And I ask patients to give that a shot. And we do get some successes. There are patients that come back that when they reduce their nickel in their diet, their hands improve. They may not clear, but they improve. It's worth it for the positive patch test and hands and feet.
Very good. Thank you very much. A question for Dr. Silverberg. Somebody mentioned foot dermatitis. So we talked a lot about hand dermatitis, and we know that some of those patients also have foot dermatitis. So the question is, in your practice, if patients also have foot dermatitis, would your approach be different? Would your treatment be different for those patients?
It is a great question. I think the approach would largely stay the same, but you know, there are nuances there that need to be, you know, appropriately considered when you're counseling patients. So in general, when patients have a combination of hand and foot eczema, there may be a lower rate of positive patch testing, but we would certainly encourage patch testing in those patients to make sure we're not missing any reversible allergens. You may see a higher rate of atopic disease. That may be a possible subset where, when we're thinking about some of the newer therapies or emerging therapies where type 2 blockade, like with dupilumab, may be potentially more effective in that subset, though that's speculative right now, and we need more studies to sort that out. My experience in terms of hand-foot phototherapy for the combination, while a little bit longer sessions and a little harder to do, generally is as effective as hands alone. Similar experience with other off-label use of oral agents. So I think the approach is the same, but we have to recognize that there may be a very different profile with respect to contact allergens and risks. And I think it's also just important to understand the burden of foot eczema can be enormous. Challenges wearing shoes and difficulties, and people even falling from the pain and some of the issues that come up with that. So we focused very much on hands, but the burden of foot eczema can be just as bad, maybe even worse.
Thank you very much. Dr. Gutman, a question about treatment. Somebody wanted to know if the anti-IL-13 antibodies would, and this is speculation, work as well as a dupilumab in the treatment of hand eczema.
Yeah, that's a very good question. So, right now we know that dupilumab, and that's from the mechanistic studies with dupilumab, doesn't work only on Th2, but also modifies Th22 and Th17. And that's why dupilumab does work seemingly in hand eczema. We do not know if it works in all of the hand eczema, but certainly works in some forms of hand eczema. And I think with the IL-13 antagonists, first of all, there are no mechanistic studies done. So it's an unknown if it will modulate more than IL-13. And we do not know what types of hand eczema. My feeling is that they will, but we do not know how much of hand eczema and which subtypes they will modulate. We'll need to learn.
Very good. Another question for Dr. Agner. Somebody asked how long you treat with topical treatment, how long topical treatment is prescribed for chronic hand eczema, and how many cycles per year for severe chronic hand eczema?
Yes, it's also a difficult question, but in my country we have guidelines for that, and I would like to say that 8 weeks. Treatment once daily for 8 weeks, that would be the normal procedure, and then we would continue with what we call proactive treatment, meaning that we treat 2 times weekly, for example, 1 time Saturday and 1 time Sunday. And that would be what we recommend to our patients. But then, of course, if they have a flare, they have to go back and treat every day, maybe for 1 or 2 weeks, and then they can continue on the proactive treatment afterwards. And I think I can't give any rules for how often you can do that, but of course you have to prefer the proactive treatment where you don't treat every day.
Very good, thank you. A question for Dr. Cohen. If a patient is allergic to latex, do cross reactions for food come into play?
Well, if they have immediate type hypersensitivity, there will be clinical consequences of cross reactions, banana, kiwi, avocado. But as it relates to hand dermatitis specifically, I think that needs to be dealt with on a case-by-case basis, right? Patients can have contact urticaria when they're cutting the food or handling the food, and they may have generalized reactions to that. I think the careful distinction here is contact dermatitis from rubber additives versus immediate type hypersensitivity for latex. And I think in the context of hand dermatitis, we're talking about contact dermatitis to accelerators and antioxidants in rubber, and not so much immediate type hypersensitivity to latex protein, at least most of the time.
Very good. Then our last last question, because we're approaching the closing. It's a tough question, so you will have to be succinct. For Dr. Silverberg, somebody wanted to know what should be the approach for systemic therapy in children? So many of us don't see that many children, but what would be your suggestion for children?
That is an excellent question, and one where we sorely need more data. Some general differences between pediatric, first of all, hand eczema in children is markedly less common it's almost non-existent relative to how common it is in adults. And it really starts to pick up from an epidemiology standpoint around adolescence. So in younger kids, they're often referred for patch testing. Often we strike out and we don't find relevant positives. They tend to be more part of that atopic spectrum. And so with that consideration, I mean, certainly phototherapy would be an option. We certainly should be patch testing those patients, but be prepared for the possibility that there'll be negatives. But when thinking about the higher rates of atopic disease concomitantly in those patients and the fact that we see more patch negatives, there may be a greater role for something like dupilumab in that younger patient subset. But until we have studies, we just don't know.
Very good. Thank you very much. So I want to thank again all people who presented today. Great talks. I want to thank the audience for staying more than 100 until the end. So thank you all and have a very good evening or very good afternoon.
Thank you. Bye.
Bye. Thank you.